after our sessions today. We have an amazing afternoon planned for us, offering a fresh perspective on how healthcare systems can work together more effectively. We truly know, I believe, collaboration is the key to innovation, and we have all the people we need to solve the issues in our world right here in this room at this conference. It's all about aligning ideas, opportunities, and coming together. Our next keynote speaker embodies this energy, has been a supporter of our conferences for many, many years. His keynote is titled, Welcome to the United States of Healthcare. In this session, Precision Healthcare Technologies co-founder and CEO, Doug Sparks, will reveal how his team successfully connected 17 distinct sectors of healthcare and consumer health with no added cost, no new technology to learn, no workflow changes, and no integrations required, all while delivering guaranteed profit for every stakeholder involved. This overnight success was 18 years in technological development and 8 years of model iteration, culminating in a breakthrough alignment of incentives where every participant wins. Let's welcome Doug to the stage with a warm round of applause. Doug Sparks is the chairman, CEO, and co-founder, again, of Precision Healthcare Technologies, one of our sponsors for the conference.
I'll leave my phone here so I forget. Does this work or is this one? Just this one? Hello, thanks. Welcome to everybody being here. Thanks for being here. Before I start, I kind of want to just follow up on what she said. I've been in healthcare for 39 years. I was a Wall Street guy for 8 years. My mentor represented companies at Wall Street for 45 years. In breakfast in 1987, he sat me down and said, I'm worried about your health. 120,000 air miles a year, you put on 70 pounds, I'm afraid you're going to die. I think you should move into healthcare. And he says, I'm going to date you because I'm 72, but if you remember the movie The Graduate, Dustin Hoffman was told the future was plastics. He says the future is healthcare. He said there'll be, in 2007 to 2010, there'll be the greatest demand for healthcare services in history, and frankly, doctors aren't known for their acumen. So maybe you should get involved in that. You might be somebody in 20 years. Well, 39 years later, I'm still trying to make him proud. But we didn't get here by ourselves. Like Tony Robbins said, a plane on the way to Hawaii is off course 99% of the time, but gets there because of thousands of small adjustments. I make thousands of small adjustments, but I get there because I work with people like you. And so I'd like to take this point here as long as I've been around in everything we do, I just like to say it anytime I'm here. I've been to these since 2018. When I first heard from Jatin what the idea was going to be, I don't invite competitors, I invite collaborators. Then I said, oh, so you mean the people that are here, we can actually work together. We're not like guarding our secrets and stuff. And that intrigued me. And so I've been to every one since then except one. When I couldn't make it. But it's the only conference I go to, and that's why. He's been fantastic. The team's been fantastic, and I will be at everyone I can possibly be. But with that said, we're talking about the United States of healthcare, not the United States of healthcare. And I can tell you that it's going to be beautiful and simplified. And we've got some, I don't want to call it intelligence because that's not the right word to use for it, but they'd call it intelligence and technology. But here's how it worked. My technology partner in New York, Ray Vono, was on the bleeding edge of electronic medical records. He had a publicly traded company before doctors even had to use them. So in 2007, CMS went to him and 4 other collaborators and said, hey, we're going to start building out this thing called value-based care. Would you help us create what the grading compliance looks like? Well, for 19 years, he's been doing that for them and 22 other payers. So we have the master blueprint of how everyone's graded. So I can tell you to the dollar how much money 1,061,000 providers are missing in miscompliance data. So this is the top of the governance, as they say. But what makes it unique or interesting is that each time there's a new encounter, the CMS standard of care is what we all obey to, whether we admit that or say it or not. The CMS standard of care is very simple. It just says where medical necessity is found, you must act. And that's whether you have insurance or not insurance. That's whether the person is a consumer or not. You have that liability as a provider and responsibility as a provider. So what our system does, it identifies, validates, documents medical necessity before it leaves our system. So what does that mean? Every time there's a new encounter, new medical necessities are updated. And you don't know they're happening, but we built the system. We built the grading system. So what we do is say, and I'll tell you how it got this way, which is kind of funny. We met with a guy in Tennessee who'd taken 6 companies from zero to billion-dollar companies. He actually corrects me and tells me his last one only got to $980 million, so don't say 6. but I'm going to go with him. But we sat down with him for 2 hours on a 30-minute meeting schedule. And at the end of that meeting, he says, Doug, me and Ray, he says, I've been in healthcare for 50 years, and there aren't 30 people who understand 30% of what you just said, but this is the answer. What can I do to help? I said, well, I'd like some networking and some input from you. And this is the advice he gave me. So Wall Street, fast forward, now I've got this mentor. He says to me, I'll tell you what, when you can connect all the different sectors, he says, because you have the ability to connect them now. You are defining, validating, connecting medical necessity as it happens in real time. All they got to do is say where to connect it. I'm telling you where your balls are dropped. For example, the guy that we show is a PCP in Brooklyn. He's missing $333,901. So we say to him, he says, well, what does that mean? I said, well, you're being penalized for not taking that money. I said, what it means is medical necessity was found for that number of services that you didn't act on. He said, well, how am I supposed to know that? I said, you don't. But that's what I talked Ray into 8 years ago. I said, you keep telling me this is like the tax code. It's got rewards. It's got penalties. All I'm seeing is the penalties. Where's the rewards? Because you kept telling me, I says, you're building this giant bear trap. And guess what? They're going to be finished with you. They're going to take this technology and move. Wouldn't you rather help me tell 100,000 doctors or organizations exactly to the dollar what they're missing than go get it for them? So back to the conversation in Nashville. He says, when you can connect all sectors of healthcare at no cost to them, at no workflow change, and everybody has an exponential benefit. So if you're in one sector, you're benefiting from the clients, providers, patients, and customers of the other 19 sectors who'd never hear from you. You can connect that today, but if you're connecting that today, then we can make that happen. So it had to be free. And so what we do is we build a care navigation codes and we share that with the provider. It comes to about 6%. But when I say to the provider, that's pretty simple for him. We'll get back over that in just a second. But when I'm talking to him, I say, the 333,901, he says, what does that mean in real terms? I'm not seeing any penalties. I said, well, let me pull up this code. I pulled up a series of codes through some friends we have. And I said, just in your area in Brooklyn, here's the contracts of the people around you that have a similar practice. Notice that the compliant provider is getting $352 for this code and you're getting $179. And there's 42 pay levels between these two. And you think you're negotiating, but that price has already been set. And our algorithm set it. So please let me help you. The same system that's grading you and giving you these penalties, all you have to do is enable us to turn it on and pick up those connections. You're just going to tell us where to connect them. We do it electronically in the background. So we call it the precision stealth workflow intelligence because you never see it. It's like electricity and wind. We're there whether you like it or not. We're giving you grades every day with our algorithms. And I'm just saying, please let me help you. And so we knew that for us to be able to scale, we'd have to be able to work between them. So how do you do it without integration? The way it works for us without integration is that we do everything from the outside. We get all of our data from the payers. We get all of our updated data. We call your current data currency. We get all updated directly from the patient themselves, and then that generates the medical necessity where they need. The provider tells me where they want to go. I electronically engage them either with a link, an email, or a phone number, so there's no workflow changes. They're doing the same thing they've always done. They're just telling me how the traffic comes in. But look at it this way. All of healthcare is trying to put the toothpaste back in the tube or try to round up the horses after they're out of the barn. We pre-stage the entire race before they leave the barn. So what we start with is a billable encounter. Doug, can you bring that one up again with the 333,901 on it, that PCP? This is a typical PCP, by the way. I pulled one yesterday for another group that's 500 something. I got a guy in Hawaii who's missing 1.43 million. Yeah, I'm not seeing it. But anyway, so in this particular case, the guy really believes he's doing everything. And the first thing I have to tell him, it's not your fault. You have no way of knowing this because every time it happens. And so there it is right here. So that gives you 16 quality measures. And you have to be at 60% or all quality measures or you face penalties. They're saying, where's that written? I said, it's written in the algorithms. Well, how are we supposed to know that? You don't. So that's why we had to make ours free to access to everybody. So that's what happens. So that's your care gap. You know what we need to find out now? We need to find out which patients need what services. There's 16 of them. So we do a billable encounter for the entire patient population. Now we are only going to get paid on about 30% of them, but we do them anyway because we own the technology. It doesn't cost us anything. So why would we do that? Well, first of all, in the value-based world, if you didn't bill it, you didn't do it. And so even if it has zero claim value, if you didn't do it, and I tell people all the time, you're probably doing hundreds of these things and not getting compliance credit or revenue because you're not doing it right. So, I mean, we can even monetize your schedule reminders and appointments by pre-staging the visit, having things ready before they come in. So a good example, I'm talking to Blue Cross Blue Shield of Hawaii, 770,000 patients. It doesn't cost me 1 cent And how much value is it to you? It doesn't cost me 1 cent to get a health risk assessment, a general anxiety and depression, a social determinants of health for every one of your 770,000 people. Now, when I get that back, I'm going to share that with the provider with care escalation so that you're not doing duplicate or other services. The guy says, what do you mean? I said, okay, you go to your doctor, you need a blood test. He sends you home, you get it, then he calls you back in. What if they had a blood test in advance, and by looking at the results, you didn't need to see the patient? Then, I mean, how did that change things? What if you saw they're eligible for chronic care management, which, by the way, only 4% of people who need it are getting it. So, it's easy for us. We've created electronic versions. We've completed subscription versions. We've completed free versions. I mean, one of my guys in Hawaii likes to focus on the homeless. Well, they don't have any money, so we have to get access and resources free. So one of our partners who couldn't be here today, she's got 632 care managers around the country who are putting all their resources into one database. So that when we put that out there, people have choice. Our objective is to say, okay, in this new world of healthcare, the consumer is going to drive it. And as the consumer drives this healthcare, here's what they want. They want access to options, pricing, and immediate connection. They want to know if I can pay cash, subscription, use my insurance, or any combination. So let me give you an example. Today, 30% of primary care is not being billed to insurance because they can't afford the co-payments and deductibles. We've created models for that. We've created subscription models. So, for example, one of them is based on, I'll tell the story, you guys probably know it, but Walgreens spent $6.2 billion buying controlling interest of Village MD so they could have walk-in clinics for the pharmacy. Didn't work. Guess why? That's really expensive. We set up collaborative relationships between pharmacists and between providers. We had the exact same model. It cost them nothing. So what does that mean? It means if you have a minor illness or if you had a prescription need, you go right to the pharmacy because the pharmacy and your physician have a collaborative agreement. So that doesn't block his office, but he's still able to earn revenue. Do I lose you here? Okay, sorry.
Oh, it's a battery. Talk right in this one.
Hello. Can you hear this? Hello? Hello? Okay, there you go. All right. Okay, so the overview or the idea is that when you give patients a choice, then they can buy. For example, a pharmacy. The way that worked for us is you can go to the pharmacy. Think about this. For $60, you can have 4 visits a year, all your labs, a PGX test, and go right to the pharmacy and have whatever the drug cost is. You know what's happening for the ACO and Medicare Advantage? It's not going to their bottom line because it wasn't billed to insurance. You know what's happening to the patient? They don't have to think about copay or deductible. We have another one called a community concierge. What does that mean? Direct primary care and concierge, they're models, but they're not models. They should be a component, just like your payer mix. So what we've done on that, which is really cool, is think of this. It's for your doctor or our network of doctors, and we've got big networks of doctors we're working on, which I'll share in a minute. But in those particular cases, for $60 a month, now all of these are family shared, by the way. So for $60 a month, you can have 4 office visits and 4 virtual visits with your provider or ours, and anybody in your family can use them. For $105 a month, you can have 6 visits a year, live visits in the office, and 6 virtual visits that your all family can use. So they're all family shared models. And why does that matter? Here's the catch right here that we've not talked about yet. When you connect, right now we're at 20 sectors, not 17, so 20 sectors of healthcare and consumer health. The number one barrier to a consumer or patient getting care, and this is why we had to address this, is health records, control of health records. Now, Google Health spent $200 million trying to democratize health records. And I spoke directly with the head of Google Cloud Healthcare Worldwide, worked with her on this project to say, firstly, thank you guys for being the hero. Thank you for being the pioneer and trying to do that. Tell me what happened so I don't make that mistake. Well, they tried to integrate. You can't do that. I said, you got to give the patients and consumers complete control of their records. So we have 5 models now between free and $9.99 a month the whole family can use. Why do we do that? Because when you're connecting 20 sectors of healthcare and every time it has to stop to request a health record, we're serving no one. So we didn't click because we had to do it. And there'll be a lot of people come out with health records. I want them to. But without our precision stealth workflow intelligence, you won't have defined medical necessity. Obviously, on the billing side, the insurance side, that's important. But it's also the liability and responsibility to validate that medical service. Because think about it this way. If consumers are buying their own, they're going to be sold a lot of stuff they don't need. I want to validate they need it or don't. Then if they want to buy it, then buyer beware. But at least you validated and documented the medical necessity to determine if they do. So it's a consumer protection is the way I see it. So let me give you a real number that's going to surprise you. In our very first pharmacy that we launched with, we have, by the way, we have 20,000 pharmacies and 80 million consumers about to hear this conversation. And in that, our very first pharmacy had 14,879 patients. Okay. You know how many of those used insurance? 323, 2.17%. And 90% of them have insurance. They can't afford to use it. We have to bill for the consumers. So we're partnering with some other bigger organizations. A couple of guys from what's called the PayPal Mafia are recreating property, casualty, and life insurance. They're going to partner scaling this part with us, community. We have 250,000 insurance agents that are going to be saying your best health and life assurances, have your records on your phone. The bottom line is when you walk in, they already have them. You know what that means? Doesn't have to go in the EHR. Why would it go in the EHR if you're not billing it anyway? Why put them and jump through that hoops? Let's just let them walk in with their records. And by the way, if we expect our target audience to be 150 million consumers who are going to hear this message in the next 3 months. So 10% participate and download the free health records. And I've written a book on called the Healthcare Escape Hatch. It's about navigating consumer health because you own your health records. And so they're getting those 2 free gifts just to come to the website and register. When they come register, now they're going to see what their same thing, their access to options, pricing, connection, whether you want to pay cash, subscription, or insurance, or any combination. And that's how the world's going to look. So now think of it this way. We have 5 million, 15 million people that are looking for providers. If you want us to give you these new patients that are already signed up in cash pay programs, you're going to have to enroll your patients in this. Because if you don't, then you don't understand the system. And if you don't understand the system, you'll continue to be part of the problem. So we're paying you to do this. We're paying them to offer health records. If a person subscribes to any of those, we pay the provider because we want them to empower them to have their own health records. It's got to be we the people controlling, and you make the decisions. Guess what happens when you make the decisions and 150 million people hear this message and now you have the control? Healthcare does what we need it to do. We all know the best ways to do it. And I'm just going to be honest with you here, just straightforward. We are the air traffic control tower, air traffic controller, and air traffic control staff. We do not deliver any services, but we validate and drive medical necessity to your services. And so it's a real simple thing. So, for example, I've got 2 people over here. One's Sherry Lucas, if you'll kind of stand wave. She handles that. Like, for instance, if you're in a particular state and you want to look one of 6 or 7 of the different 16 quality measures, she's going to give you 2 or 3 options of the best vendors that can do that. We're not involved. We're not involved in that money. Now, back to the one thing we showed here with 333,901 for this provider. He gets to keep the whole 333,901. I don't want to be in there, but he'll never get it if we don't navigate it because our scorecard came from our algorithms. So he's missing that because of what we can pick up and correct for him. He'll never get that without it. So how do we get paid? Well, we're going to build electronic care codes, and we're going to get paid on about 30% of them. Why? Well, think of it this way. Again, we have to remember, you can't bill for reimbursement. You have to bill for compliance. In the value-based world, it's real simple. If you didn't bill it, you didn't do it, even if there's no value. So a lot of people don't bill it. But to give you an example, we're going to come back on any ACO or Medicare Advantage. It's going to come back and tell us, not a covered service, we're not paying you. I don't care. It didn't cost me anything. But you know what? If the doctor doesn't get that attribution credit, he doesn't get a capitation payment for that patient. So I need to help him. I need to do that. I don't care if it pays. There's another 2 stupid rules about it. And I can say stupid because I know you guys will cheer when I say that because you can all preach in the choir with you guys. But you can't build this code if you're going to see the patient within 7 days. I mean, that's when I need the information. Are you kidding? You can't see it if it's a new patient. Excuse me? That's when I need it. So we do it anyway. We don't care if they're paid or not. And so the way it works is we're going to actually complete the encounter, move it in their EHR, submit the claim, tell them when they're paid, and they will get to that 333,901 because we navigate. Ours is about 6%. Now, that's 6% on top of the 333,901. That's the care navigation. That's part of the rewards for value-based care that say, like the tax code, we reward you for behavior and we penalize you for not. Well, the reward is you're getting paid 6% to do this, but you're going to get the 333,901 you keep. Now, here's the trick. We split that 6% with the provider. We take 10% off the top. So he's not only getting 333,901, but we're also sharing our 6% with him. He gets half of that navigation after we've moved everything into a system. Why? Because we can't ask them to do anything. We can't ask them to learn any technology. We can't ask them to burden their staff. We can't do anything. And that's why it's called the precision stealth workflow intelligence. It's in the background, invisible to them. Now, I tell them this all the time. I said, look, it's real simple. The same system that's creating these penalties for you and giving you that grade can fix you with the same effort and cost. It's not costing you anything. Well, it's costing you something, but you're not paying to get that score. It's not causing any work to get that score, but yet you're getting it. I can turn that same system on at no cost or effort and make it help you. You just got to get out of our way and let us do it. So good examples, and this will give you some scale for this. I was presenting to a hospital CFO roundtable in Florida, 18 hospital CFOs there, and I had reports on 8 of them. So this one lady says, wow, this sounds great. She says, but I've got 213 providers, and I'm missing $42 million I'm being penalized for not taking. And I said, yeah, exactly. She says, well, what do we have to do to help you? I said, with all due respect, just get out of our way. I mean, it's grading you now. So let me give you another example. I'm telling you this because the big organizations are nothing but made up of everybody from the mom and pop to the other ones. We service every single one of those providers individually as if they're the only practice we're with. You tell me how you want everything, we escalate them that way. So let me give you a couple of other examples that'll really put some frame to your thinking. We went to a company, and I'm not going to say where the name. We've got a really powerful attorney partner. He wrote the Stark and Kickback laws for Florida that the U.S. government copied. He's taken Medicare to court twice and won. I mean, he's that guy. But he's also the attorney and our attorney for this big company. They've got, think about this. They have 704 providers. So they're telling me, I don't know what you can do for us. We're a really big company. We have 704 providers. We spend $200,000 a year on data. We have 70 people working on patient engagement. We have 50 people doing RAF scores. And so the attorney says, then how come your report cards are so bad? He said, what do you mean? Well, 704, the first 10 were missing an average of $353,000 each. I said, you're chasing the ghost. You're chasing what they think you want you to do. You're chasing the horses when they're out of the barn, and you're guessing wrong at great expense. And they just couldn't wrap their head around that. And so when you look at that, now here's the one that'll really get you. And the reason I'm telling you this, I want to give you some perspective that this is, when the guy says only 30 people in the country know about this, 30% will understand it. You guys are in that group now. You're getting it. You're getting the crash course in 30 minutes. But I'm talking to regional presidents of Humana, Kaiser, and United about a month or so apart 3 years ago. And in the conversation, they're trying to get their annual wellness from 40% to 60%. I said, well, you've got to have 60% of all your 16 quality measures, and your guys have them on like 2 or 3. And they're like, what? I mean, they didn't know that. So I'm like, okay, well, let's play your game. Let's just say you want 60% compliance. Let's say you get 100% compliance. And they all laughed out loud when I said, no, 100% compliance is easy. I'll explain how. And so I said, even if you got 100% compliance, 100% participation, you'd still be penalized for failing to act on the new medical necessities found within those results. All 3 of them present said, huh? They don't know it. Nobody knows it, but we built the system. Do you know that you're required to do a health risk assessment 4 times a year to do a risk stratification? And during that risk stratification, you're required to see virtually or live all your moderate risk patients. I just say, how would you like that scheduled? Do you want me to use a link, an email, or a phone number? I put it in the autoresponder. Same thing on a high-risk patient. You're required to see them in the office and have a live or virtual follow-up. How would you like me to schedule that? Give me I don't want to be in your schedule. Just give me the link, give me the email, give me the phone number. So they're not changing their workflow. We're just feeding the system, but it's being fed in a controlled way. So we're talking to a doctor in a big hospital in Florida. He's like, I love the program, but I couldn't possibly see another person. And I said, well, let me tell you, we've been with you 2 months now. I can tell you that 64% of the people you're seeing, you didn't have to see. Another staff member could have seen, or they shouldn't have been seen in the office at all. 64%. What if we remove those from your patients and we put those in the right place where you actually had the appropriate staff and service matchup? And he had no idea. But when I showed it to him, he's like, my life would be so much easier. I said, again, please we have to get them out of the way because I'm going to say this the most respectful way I can because I know you all know it. They are well-intentioned, but they will not do one thing you ask them to do because they're doing, and you know how it is in a doctor's office or any kind of organization. You got 6 people doing 1/6 of 6 jobs, and then the person on vacation, the person on medical leave, the person doing another thing. They're all doing these things. And by the way, what about turnover? How are you going to do that? Nobody can follow up. So we just take it over completely. We do everything. All they do is the first outreach in their system. Everything else comes from our system. They just tell us where they want those blocks stacked. It's going to come back here. You're going to get a penalty if you don't do this. Where would you like this? And then on each one of these, they tell us how they want them connected. Now, where they want them connected are services you do. So think about it this way. When I'm talking to the head of a big chronic care management company, and he's telling me, he says, we're the biggest and the best. I like your idea, but I don't know what you can do for us. I said, well, that's exactly why I want to work with you, because you are the biggest and the best. But, you know, CMS says only 4% of people that need chronic care management are participating, and half quit before 6 months. So wouldn't you like to make money on the other 96% and turn your 4% into 12%? I mean, we're going to know there's medical necessity. We're going to engage the patient, tell them about the program, get informed consent, have them make the schedule, and nobody gave them a phone call. It's going to happen while they're at home. They don't even have to come to the office. So it was a 10-minute conversation. Yeah, we're going to enroll everybody with you. So we do that. That's how we connect these different sectors, because most people are covering a sector between 4 to 32%. Example, I've got another ACO group that I've worked with that has, get this, they have 3.5 million patients under capitation. And they do a great job. They've been doing it for 25 years. But you know what they don't make money on? The 9 million fee-for-service patients. So what do? We give them our technology and escalation completely free if they require the fee-for-service people to enroll, and then we share our revenue back with their ACO on the top line. So I said, would you like to make money on the other? So you're 30%. Would you like to make money on the other 70% and make that top line, and guaranteed you'll have a distribution, because we're escalating the care differently on the fee-for-service people for the cost-contained people? So same thing in Hawaii, and this will be my kind of last statement. Their big TV doctor who's on BBC International is a medical expert, Scott Miskovich. He's missing $1.438 million. I'm talking to the head of HMSA, which is the Blue Cross Blue Shield licensee of Hawaii. They go, oh my God, I don't even want to see that number. I said, well, look, you guys are 60% capitated. I can deliver the same compliance with a different care escalation for that 1.438 million. I could do it for 469,564. And they're like, how do you do that? It says, well, we escalate the care different. Fee for service, you have a different process, and you have things in boxes you have to check. On this, you have to escalate properly. And so that's kind of the overview of how the whole thing looks and works. And later on, I'll share a link with you. I have a link that's a short video. I have this entire slide thing that you can look at. And then I'm here, and then Doug Chenault right here is also a partner of ours. He's the one that, he and these two have spent a really, really lot of time and a long time digging into the minutia of the minutia. Like, I have 8 websites and 400 pages of information that I've written that most people don't know, just that I've learned in this process of going around, and nobody understands it. I'm telling you because the United States of healthcare is beautiful for us, because we've just simplified it. We've taken we're just saying, hey, if they're not going to build insurance anyway, why would we jump through those hoops? Let's create models for those doctors so they become the family doctor again. So anything that you have in mind is an idea. My rules in life are pretty simple. The first one is I know nothing. We know everything. The second one's mind's like a parachute, works best when open. That's how most of this stuff comes to us. The third one is, if you're doing the right things for the right reasons with the right people, number one, you want to touch the largest number of people you can. But once consumers are in charge, it changes the world. So we're hitting on both ends. So in the last part of that, it comes down to, we can always find a way with good intent. We can always find some level that we can agree to begin and to evolve and figure them out together. Because I guarantee you, in this room, everybody has a story like I had a story. And I want to hear every one of your stories, because I've always found them to be fascinating. But you're going to have some ideas that are going to be triggered by what I'm saying, and I want to hear them. Because I'm 8 years on Wall Street, 39 years in healthcare, 72 years old. I get up every morning to do this, to work with guys like you. So anyway, thank you very much for your time today. If you have any more questions, these two. Thank you.